Hello everyone, welcome to the channel of microbiology and infection control. Today we are going to see training for infection prevention and practices, and this is very important to prevent infection in the hospital premises. So general infection prevention control measures in surgical units. Now we will see asepsis for surgical procedures. Perform surgical hand antisepsis using a suitable antimicrobial soap before donning sterile gloves. A preoperative surgical hand scrub should be done for at least 5 minutes using an appropriate antiseptic scrub. After performing the surgical hand scrub, hands should be kept up and away from the body, means elbow in flex position, so that water runs from the tip of the fingers towards the elbow and not vice versa, not from the elbow to fingers. The abdomen should not be shaved prior to surgery, and if required, hair clippers should be used instead. It is important to maintain a sterile field to prevent contamination of surgical. Only sterile objects and persons in surgical attire or scrub team are allowed within this field. Scrub team keeps hands in sight and at or above waist level. Hands are kept away from the face and elbows close to one's sides. Arms are never folded because there may be perspiration in the axillary region. Items dropped below waist level are considered unsterile and are discarded. Cleaning and disinfection. So we will see about the cleaning and disinfection of operation theatre. A clean operating environment is essential to prevent surgical site infection, that is SSI. There should be no dust in the operation theatre. Lint containing textiles and floor mops can be a source of dust. OTs must be cleaned daily before first surgery, after each surgery, and at the end of the day. Cleaning should include cleaning of OT table, furniture, lights, equipment, windowsills, ledges, scrub rooms, and sinks. Thorough cleaning of entire OT should be done once a week. Accordingly, flash sterilization or immediate use steam sterilization, that is IUSS, where possible should be avoided as ideal infection control measures are not assured. So, flash sterilization or IUSS where possible and should be avoided as ideal infection control measures are not assured. Now, the components of operation theatre. The OT is a multifunctional area. In this area, patients are received and prepared for surgery. The operation team prepares for surgery and the actual surgical procedures are carried out. Equipment cleaning, processing and sterilization should be done in centralized area or a CSSD. In addition, there are areas for administrative functions, sluicing and waste disposal. The OD areas are distributed into zones depending upon the level of sterility and cleanliness required. Now, which are the various zones in operation theatre? Concepts of zoning. Number 1, unrestricted zone or clean area. Second is semi-restricted zone or sub-sterile area. Third is restricted zone or sterile area. And fourth is disposal zone or disposal zone. Now what we are looking here, so this is our OT or operating room, OR. Other name for OT is operating room. Now we will see functional and decontamination areas in OT. So functional areas can be categorized as 4 types: extreme, high, medium and low risk. Adequate lighting to minimize the risk of injury and enable inspection of clean areas and equipments. So first is priority is adequate lighting should be there, good ventilation should be there. So why good ventilation is required? To reduce risk of cross infection from aerosols. Third is smooth impervious work surfaces made from non-porous materials without crevices. Then next is slip resistant or non-slip water impervious flooring with sealed joints. And lastly, correct pins for the disposal of hazardous waste. Surgical antimicrobial prophylaxis. What is SAP or surgical antimicrobial prophylaxis? So, before the surgical incision, when indicated, it is given before the surgical incision and depends on type of surgery. And this SAP is based on the half-life of antibiotic and hospital antibiotic policy. The initial dose of prophylactic antimicrobial agent should be administered by the IV route, administered within 60 to 120 minutes, timed such that a bactericidal concentration of the drug is established in the serum and tissues when the incision is made. It should not be prolonged after completion of the operation. The patient should be educated in how to take care of the incision site, personal hygiene, signs and symptoms of infections, and whom to contact if infection occurs. Now we will see about the OT attire. First is what we are doing, drying the hands. Then next is pick up gown. Third, let gown unfold. Fourth, open to locate sleeves or armholes. Fifth, slip arms into sleeves. Sixth, hold arms out and slightly up. Then next is circular pulls gown on. Now next is protocols for IPC in OT for infectious patients, HIV, HBV, SCV and gas gangrene. So which are the protocols for infection prevention control in OT for infectious patients? Blood and body fluid precaution, standard precautions should be followed for all patients irrespective of their infection status. This will prevent the transmission of blood-borne pathogens and those transmitted by contact. For patients suffering from disease such as TB or measles or chickenpox, which are transmitted by the airborne route, airborne transmission precautions should be followed. This includes N95 respirator or mask, full PPE including goggles. Personnel working in OT should have received all vaccinations, which would include TT, hepatitis B, DPT, etc. There should be documentation of vaccinations received, the training for IPC practices and cleaning and disinfection practices. Bloodborne pathogens are transmitted by direct or indirect contact with non-intact skin, mucous membrane or needle stick or sharp injuries. They are not transmitted by the airborne route, so fogging not essential. So cleaning after surgery on infected patient. So first is what we are looking, bloodborne pathogens. They are transmitted by direct and indirect contact. So they are not transmitted by airborne route. So in this case, fogging is not essential in case of bloodborne pathogens. Fogging or fumigation is recommended only in situations when the ventilation in OT is ineffective in removing infectious aerosols, such as while operating on active lesions of tuberculosis, varicella or chickenpox or measles. Fogging is not essential following surgery on patients with other infectious diseases not transmitted by airborne route. Clostridia from clinical contact surface can get deposited on an open wound. Hence, deep cleaning of surfaces is important. So, for what we learn from this is cleaning after surgery on infected patient. In that, if the bloodborne pathogens are transmitted there, then just transmitted by direct or indirect. They are not transmitted by the airborne route. So in this case, in bloodborne pathogen case, fogging is not essential. Fogging when it is recommended? When we are operating on active lesions of tuberculosis, varicella or measles. Fogging is not essential following surgery on patients with other infectious diseases. Clostridia from a clinical contact surface can get deposited on an open wound. Hence, deep cleaning of surface is important in case of Clostridium. A separate operating room or block should be available for performing surgery on infected patients if possible. If not available, pose the infected patient at the end of the day. So for what we have to do in such case, if infected patient is there, then separate OT room or block should be available for performing surgery on infected patient. If separate OR room is not there, then we have to pose these infected patients at the end of the day. If surgery cannot be slatted for last, clean and disinfect the OT thoroughly before next operative procedure. If we cannot keep it as a last case, so we have to clean and disinfect the OT thoroughly before next procedure. Cleaning and disinfection should be done as per the routine protocol stated above. Cleaning after surgery on infected patient. The person performing the task of cleaning and should have received appropriate instructions for use of the PPE and vaccinated for hepatitis B and TT. After surgery, manage all spills as described in the spill management SOPs. Thoroughly clean with soap and water all surfaces which have come in contact with the patient or operating team, such as the OT table, OT lights, etc., without generating splashes or wet a mop fully with soap solution. Discard all used cloths and mop in yellow bag. Now we will see about the OT fogging and surveillance. Before fogging, fog the OT with an aldehyde based disinfectant. Know the volume of OT complex. Follow label instructions for fogging. Ensure that OT is sealed well and porous instruments were well covered during fogging. OT can be opened after a contact time as mentioned in the product label, usually 1 to 2 hours. The wet surfaces should be dried using a lint-free, sterile or clean absorbable cloth. Collect material for surveillance and wait for report. Now OT fogging. Fogging or aerial disinfection. Spraying of a disinfectant, example glutaraldehyde, hydrogen peroxide or quaternary ammonium compound based product with the help of a fogger machine. Fumigation with formaldehyde is not recommended since it is a known carcinogen. Or fogging of OT by using this fogger machine. Guidelines for OT surveillance, sampling methods, settle plate method, aerobic culture method, anaerobic culture method. Now settle plate method of detection is that expose one culture plate on an OT table 1 meter above the floor and 1 meter away from the wall for 30 minutes aseptically without touching the culture media or contaminating the plate lid. Now close the culture plates after 30 minutes, seal them and send to the lab for further processing. The lab will report the total colony count after 24 hours of incubation at 37 degree. So this should be done. Settle plate should be done weekly. Okay, now the second is aerobic culture method. In this, swab should be collected from the following location in each OT. OT table, OT light, anesthesia machine, instrument trolley, microscope and carried to the lab for further processing. The lab will report the total colony count after 24 hours of incubation at 37 degree. So it is also done weekly. Now anaerobic culture method. Swabs should be collected from the following location in each OT table, OT light, anesthesia machine, instrument trolley, microscope, wall and floor. For new OT or renovated OT, swabs are taken at 24 hours, 48 hours and 72 hours after fumigation. Swabs are inoculated in Robertson cooked meat media and incubated at 37 degrees for 7 days. The lab will report after 7 days. It's done for new OT before starting OT following construction or and renovation. Now there are two types of OT, general OT and the modular OT. Now we will see guidelines for operation theatres. So occupancy is standard occupancy of 5 to 8 persons at any given point of time inside the OT. Equipment load, standard equipment load of 5 to 7 kilowatt considered per OT. OT construction, paint, it should be antibacterial, antifungal. OT door, it may be automatic or hermetically sealed or touch free, preferably. General rights, clean room lights, provision of safety against static charge. There should be separate power circuit for equipment like C-arm. Flooring, it should be seamless. Ankle skirting should not be of porous stone as it absorbs moisture and could be a source of bioburden. Guidelines for OT, it includes requirements, super specialty OT. The air changes, minimum total air changes should be 25 or 20 for general OT, and the fresh air component of the air changes is required to be minimum 4 air changes, that is 16% out of total minimum 25 air changes. Air velocity, the vertically down flow of air coming out of the diffusers should be able to carry bacterial carrying particle load away from the operating table. The airflow needs to be unidirectional and downwards on the OT table. The air velocity recommended as per the international and national guidelines is 90 to 120 ppm at the grill or diffuser level. Now, positive pressure, there is a requirement to maintain positive pressure differential between OT and adjoining areas to prevent outside air entry into OT. The minimum positive pressure requirement recommended is 15 Pascal, 0.05 inches of water as per ISO 14644 clean room standard. Air handling in the OT, including air quality, air is supplied through terminal HEPA filters in the ceiling. The minimum size of the filtration area should be 8 inches by 6 inches to cover the entire OT table and surgical team. The minimum supply air volume to the OT in CFM should be compliant and with the desired minimum air change. Air quality at the supply, that is at grill level, should be class 100 or ISO class 5 at rest condition. Note, class 100 means a cubic feet of air should not have more than 100 particles measuring more than 0.5 micron or larger. Air filtration, the AHU must be an air purification unit and air filtration unit. There must be two sets of washable flange type pre-filters of capacity 10 micron and 5 micron with aluminum or SS304 frame within the AHU. Temperature and RH for super specialty OT, it should be maintained 21 C plus or minus 3 C, except for ortho for joint replacement as 18 C plus 0 and minus 2 C with corresponding relative humidity between 40 to 60%, though the ideal RH is considered to be 55%. Requirement in OT, window and split AC should not be used in any type of OT because they are pure recirculating units and have convenient pocket for microbial growth which cannot be sealed. Validation of the system to be done as per ISO 14664 standards and should include Temperature and humidity check, air particulate count, air change rate calculation, air velocity at outlet of terminal filtration unit or filters, pressure differential level of the OT, validation of HEPA filter by appropriate tests like DOP, etc. Repeat after 6 months in case of HEPA found healthy. Thank you. This is all about the infection prevention practices.